You're listening to Beyond Wellness Radio, bringing you the cutting edge in health, biohacking, and sports performance. Stay up to date and listen anywhere and anytime on your computer, tablet, or smartphone by subscribing on iTunes. Catch your host, Dr. Justin Marchegiani, as he answers your burning health questions as well as interviews from world-renowned guest experts. For more Beyond Wellness Radio, go to beyondwellnessradio.com.
Hey there, it's Dr. Justin Marchegiani. Welcome to Beyond Wellness Radio. Feel free and head over to beyondwellnessradio.com where you can access our full podcast transcriptions. While you're there, you can also sign up for our thyroid and female hormone video series. This series goes into the root cause of why your hormones are out of balance. While you're there, you can also schedule a functional medicine consult with Dr. Justin, myself, where we'll dig deeper into the root cause of your health challenges. Feel free and think of sharing this podcast with at least one person. This podcast grows by people sharing it. Sharing is caring. If you can think of one person that can benefit from this information, please feel free and share it. If you're enjoying the podcast, make sure you subscribe on iTunes. You can also click below the video or podcast where you'll see the iTunes review button and leave us a review. You can also sign up for the newsletter at beyondwellnessradio.com where you'll get updates before anyone else. Thank you so much and enjoy the show. Hey there, it's Dr. Justin Marchegiani here. Today we have an awesome podcast with Dr. Jack Wolfson, the Paleo Cardiologist. Dr. Jack, I welcome you to the show.
Dr. Justin, it's a pleasure to be on with you. We had so much fun hanging out at Paleo Effects in 2016, and I'm sure I'll be seeing you out there again. And once again, it's wonderful to talk to you. I really appreciate your message.
Awesome. You as well. Well, first off, you are the Paleo Cardiologist, and I know you kind of got into cardiology, kind of the back door. You came in through the conventional medical route, you're doing a lot of the conventional cardiology procedures, and then now you're kind of in the functional medicine / paleo world. Can you just kind of walk our listeners through how you got there?
Yeah, sure. My father was a doctor of osteopathic medicine. I followed right in his footsteps. He was the head of cardiology in Chicago, and I went through 4 years of osteopathic medical school, 3 years internal medicine, 3 years of cardiology. And then I was out here in Arizona on the job for a couple of years doing all the angiograms, pacemakers, all the fun stuff. And met my wife, my future wife, and she is a doctor of chiropractic and, like she says, a doctor of causation. And she taught me how to become a doctor of cause. And I started to change my practice, change my philosophy, get educated, open up my eyes to the reality, and it's been just very successful ever since. 2012, opened up my own practice in Paradise Valley. Our website is thedoctorswolfson.com, and people schedule from all over the world with us on that website, and it's really just been miraculous. And the reception, the results, I just can't say enough. I can only say that I wish I did it earlier than 2012 to leave the medical sickness paradigm.
That's great. And so when you first met your wife, what was that like? So did you think she was kind of a little quacky at first? Like, how long did it take you, or how long did it take her to kind of get through to you and educate you? What was that like?
I opened up my eyes pretty quickly because I saw my father, who was getting sick in his mid-50s. And he died eventually at the age of 63 of a strange neurologic disease. And I talk about this in my book, The Paleo Cardiologist, where I teach you about kind of what happened to my father. And then, meeting Dr. Heather, and she starts telling me, hey, listen, your father, eats the bad food, is exposed to environmental toxins, he's not getting the sleep or the sunshine, all these different things that really just seem so basic. And I just, a light bulb went off immediately in my brain, and I said, you know what, this is really interesting stuff. And I started to read, and I looked at the scientific literature, and a lot of the stuff that you and I talk about, Dr. Justin, is in the scientific literature. So, just looking at it from a fresh perspective, changing my practice. And, listen, unfortunately, most medical doctors don't listen to this message because they are stuck in the pill and procedure model, and they are beholden to the almighty dollar. So they're not going to make a change.
Totally get that. I had a patient that was seeing a cardiologist, and we had them on kind of like a paleo template type of approach, high quality saturated fats, keeping the carbohydrates on the lower side because they were more insulin resistant. So more vegetables, maybe a little bit of lower sugar type of fruit here and there. But this patient went in to see their cardiologist, and the cardiologist had recommended the standard American diet. You kind of know what that is, kind of lower fat, 10 to 12 servings of grains, et cetera, et cetera. And the patient asked the doctor and said, hey, well, what do you think about this type of eating plan? And he, talked about kind of a lower carbohydrate kind of paleo approach. And the cardiologist looked at him and said, well, you know what? That's exactly how I eat. But, I'm kind of hamstrung by the American Cardiology Board and what I can recommend nutritionally going outside of the recommendation. So I'm just curious on your take. It seems like a lot of conventional medical physicians are really hamstrung on what their board will allow them to talk about nutritionally.
Well, the reality is that medical doctors get just about zero training when it comes to nutrition. This is well documented. Even out of Harvard Medical School, they get very little nutrition training. So, unfortunately, your medical doctor is just about the last place you're going to go for nutritional advice. And frankly, look at most of the medical doctors. They're overweight, they're unhealthy, they take drugs themselves. So, they're not the right person to go to. And as far as I'm concerned, listen, I'm getting people better. I'm telling people, the right nutrition plan. Paleo is the way to go. Our ancestors did it for millions of years. And, frankly, if there's any doctors that are listening, any medical doctors, guidelines are guidelines, but it's not, it's not the law, a letter of the land that you got to follow, quote unquote, the guidelines. We can step outside the guidelines a little bit when we're doing what's best for our patients.
Yeah, even conventional dietitians that are in a hospital, it seems like they really are restricted to that food pyramid type of approach. Think of the last, really good meal you had at a local hospital, right? I can't think of any.
Well, hospital food is totally embarrassing, and I talk about this certainly all the time, is that, can you imagine, Dr. Justin, walking to a patient's room, and the patient has diabetes. They're on a diabetic diet, and what do they have on their plate? They have a stack of pancakes and sugar-free syrup. It just can't get any worse with that microwaved artificial food, that they're serving. The hospital is the sickest place in the world. I tell anyone who I know who's going into the hospital, and fortunately we're able to keep a lot of people from going to the hospital, but if they do wind up there, they do need some form of surgery, bring your own food, have a loved one bring in the food, get a nice, high quality protein powder, bring your greens drinks in, do everything you can not to eat the hospital food.
Absolutely. I 100% agree. So kind of switching gears a little bit to cholesterol, because you're a cardiologist, that's the buzzword. Everyone's going to be looking for that type of topic discussed here. How important is cholesterol to you when looking at someone's health? Where's the cutoff where it matters and where doesn't it matter?
Well, first off, I educate people and tell them the importance of cholesterol, that every cell in the body has cholesterol, the cell membrane, which is that protective fence around the cell that lets things in the cell that belong and keeps things out that don't belong. It's a large part of the cell membrane and how hormones and other vitamins and minerals interact with the inside of the cell. We see people that vitamin D comes from cholesterol, and digestion as far as bile acids and bile salts come from cholesterol. Cholesterol makes up all of our sex hormones and cortisol and aldosterone. So we teach them the importance of cholesterol. But then we start diving in deeper into their numbers, and I talk about this extensively, of course, in the book, and total cholesterol and things like that. Listen, when your total cholesterol is super high, let's say numbers of 300, 400, that's definitely a problem. There's no doubt about it. But anything below 300, we certainly want to look at the breakdown as far as LDL particle numbers, particle sizes. Same thing with HDL. That ApoB, ApoA ratio is the number one risk factor that we know of when it comes to lipids. So let's go beyond the 1970s testing and get the state of the art 2017 and beyond tests. That's what matters.
Okay, got it. So let's me kind of run through some hypothetical markers here. So in my clinic, one of the big things we'll look at is I'm a big fan of the triglyceride to HDL ratio. If we see the trigs go too high, that can be a big sign of excess carbohydrate and insulin resistance. Any feedback on HDL to trig ratio?
No, I think if you are going to use a 1970s panel, and I think the panel you're talking about is actually very important as well. I think that gives us a good surrogate as far as their cardiac risk. If you're producing too many trigs, like you said, from too much carbs, too much sugar, insulin resistance, that's clearly in every study, linked to cardiovascular events, cancer, on. And that low HDL, is so important, but when you look at HDL, it's nice to break it down into the ApoA1, and the ApoA1 is a protein that's on the surface of the LDL, and that really has to do with HDL functionality, because clearly we know from studies where you raise HDL, certainly with pharmaceuticals, or with estrogen, for example, it didn't change outcomes. In fact, it may have made outcomes worse. So raising HDL as far as a number is not necessarily a good thing. We want to raise the ApoA1s, and which is a sign that we are improving HDL functionality, because HDL functionality is really the key, because HDL is responsible for reverse cholesterol transport, where you're basically pulling cholesterol from plaque and recycling it back to the liver. That's what it's really about.
Great. So when you're talking about increasing that ApoA1, is that what you said? That's primarily going to be done with what? Healthy saturated fats like grass-fed meat, coconut oil, and even fish oil. Is that the best way to improve those levels?
Well, I think that sunshine, physical activity, basically, the whole lifestyle that we talk about. And, one thing where I'm super big on now is really getting people to use a lot of spices, because even the best paleo eaters, maybe they're eating their, grass-fed ground beef, and they're eating their, wild seafood. I mean, they're doing a lot of good things there that we, espouse in paleo. But two things I think they're missing. They're missing, number one, the organs. Liver, kidney, thyroid, thymus, adrenal, that our ancestors ate as their first choice. They weren't reaching for filet. And then number two is the spices. And if you look at the spices in the medical literature, man, I'm putting together another blog post on this. Spices are little natural pharmaceuticals. In fact, the pharmaceutical industry, no doubt, came from the spice and the plant industry.
Totally.
And a lot of these spices are proven to increase ApoA1. They're proven to increase reverse cholesterol transport, it's real exciting. And they, of course, do wonders in so many other cardiovascular factors, including LDLs and upgrading LDL receptors on the liver. So add those spices early and often.
So we have the ApoA1, you said, and then the ApoA2 is the kind of the negative marker. Is that correct?
Yeah, I mean, it's, the ApoAs, certainly the most literature right now is on the ApoA1, and that's clearly going to, demonstrate the best as far as functionality of that HDL particle.
Great. And then the things that are going to make the ApoA2 or the negative APOs go down essentially the wrong direction are going to be what? Trans fat, extra refined carbohydrates, insulin resistance, inflammatory foods, gluten, those kind of things?
I think you're right. All the bad stuff that we all talk about, clearly it's associated with it. You talked about it before, the, omega-3, kills me that so many people are following this vegan plan of the China study and,
yes.
and the fireman, who wrote a book on nutrition, with all due respect to firemen. In any case, every study shows that fish eaters live the longest, and it's so clear on the benefits of omega-3 when it comes to lipids, and it comes to inflammation, and it comes to insulin resistance. How you can't get omega-3 from sucking down walnut oil. You have to eat fish. Plain and simple. You eat fish. You eat shellfish. Avoid the large fish, because unfortunately they are high in heavy metals. So we talk about fish, we're talking about wild salmon, sardine, anchovy, and those smaller fish. And I've got no problem with seafood. I test people's heavy metals. When you're getting high quality shellfish, I think you're in good shape. Maybe I wouldn't overdo it, but I've got no problem with shellfish, 1 or 2 times a month. I mean, oysters. How miraculous is an oyster? And then why can't a vegan eat an oyster? I mean, why does an oyster have any more feelings than a head of cabbage does?
Exactly. Yeah, totally. And I've seen lots of patients who are vegan, and this is really hard for a lot of people to get their head wrapped around. I've seen a lot of patients who are vegans, and they actually have elevated cholesterol. And when I educate my patients, I tell them diet has very little effect on your cholesterol. If you look at the enzyme that the statin blocks, the hemomethylglutarate-CoA reductase enzyme, the HMG enzyme, one of the biggest things that stimulates that enzyme is insulin. So you have many vegetarians and vegans that are on a crapohydrate diet, and the extra carbohydrates feed that insulin, and that causes more internal production of cholesterol. So I see dietary cholesterol actually has very little impact, and I eat about 60 to 70% fat. My cholesterol is still under 200, and my trigs are at a 1-to-1 ratio with HDL, probably at 60 and 60. Any comments on that?
Well, listen, LDL, HDL, these are all part of the immune system. And when you eat bad foods, or you eat gluten-containing foods that are damaging the intestinal lining and leading to the leaky gut, well, leaky gut leads to inflammation and immune system activation. When you activate the immune system, you're stimulating the production of the repair crew, LDL and HDL. So it's not a surprise that they're elevated. But a lot of times, vegan diets can dramatically lower lipids, and I think in most cases it's too low because two things. Number one, you're not giving the body the tools it needs to make cholesterol. That's number one. Number two, when you're avoiding fat, then you do not need to make the cholesterol to put into the bile and bile acids, bile salts to digest fat. So, once again, it's kind of twofold. You don't need to make the cholesterol because you're not using it in the gut, and you don't get the tools your body needs, and you suffer the long-term effects.
I agree, and I think it's the vegans that are more insulin sensitive, meaning they don't overproduce insulin, their cells aren't numb to insulin. Those are the ones whose cholesterol really drops, and I agree, and I see that frequently. Now, in my practice, we find that upping the cholesterol, increasing the saturated fats, there's many studies, meta-analysis, many studies that are conglomerated together to look for correlation. They find that there's no correlation between saturated fat, cholesterol, and heart disease. I think the Framingham Heart Study echoed that. What do you think?
Well, that was definitely found in Framingham, and 2010, the American Journal of Clinical Nutrition, the biggest nutrition journal in the world. They looked at 350,000 patients, and concluded fat has nothing to do with cardiovascular disease. I believe it was 4 years later, in 2014, there was another analysis of over 500,000 patients. So, yeah, the data is very clear. Sat fat is not linked to cardiovascular disease. Sat fat is great for cooking. And most importantly, our ancestors have been eating sat fat for 1 million years, and animals eat sat fat. Breast milk, the healthiest food on the planet for a newborn baby up until they're the age of 3-4 years of age, is breast milk is loaded with sat fat. So I think that pretty much ends that debate.
Yeah, I totally agree. And you kind of talked about the HDL and the LDL. You mentioned it earlier. I just want to emphasize it for the listeners. But people are out there always talking about good cholesterol, bad cholesterol. And one of the things I echo to my patients is cholesterol, like LDL or HDL, are good or bad. Those are just the buses. The LDL is basically the bus that takes cholesterol from the liver out to the peripheral tissues to help repair and fix whatever's going on. Cholesterol is a powerful antioxidant. And the HDL is the bus back home. It's the bus back home from the peripheral tissue back to the liver to recycle that cholesterol. Can you echo or comment a little bit more on that topic?
Yeah, no, I agree with everything you said 100%. The LDL has been vilified by the pharmaceutical industry, and therefore, they push it on the medical doctors, and the medical doctors tote that same jargon. I mean, why would the body make LDL if it didn't have some role and some benefit? If LDL is the bad cholesterol and our body makes it, is our body programmed to kill us and cause heart attacks? Why do animals make LDL particles? Why do animals make HDL particles? There's a reason for all of it. And just as you said, we measure the good and the bad amongst the LDLs. There's good and bad LDLs. There's good and bad HDLs. And we measure those levels and make recommendations based on that.
That's great. Now, what kind of particle size test are you doing? I was doing the VAP by Atherotech, but they closed down recently. So I've been looking at the NMR and as well as the Cardio IQ. And for the listeners, the particle sizes have to do with basically how big or small the LDL or the HDL are. And I tell my patients, big and fluffy particle size A, you want the A on the test, so you want the larger fluffy particle size A, and you will want to avoid the B for bad, the small atherosclerotic dense LDL particles. Can you comment on that a little bit more? And what lab test are you using for your particle size testing?
Well, I think, as you said, there's a lot of different companies that are out there. I personally use Vibrant America for my lab testing, and they do an amazing leaky gut panel. So really excited about that company, and they're started up a few years ago, getting really, really high quality results from them. I've used True Health Diagnostics, but like you said, Cleveland Heart Lab, Boston. I mean, there's a lot of different companies that are doing advanced lipid analysis. And I think the important thing is just to get that testing done and get that information.
Got it. So you're looking for more of the A's, less of the B's, generally speaking.
Well, I mean, like I said, the number one risk factor we know of is that ApoB to ApoA ratio, and you get that ratio down below 0.6. You're in a pretty darn good place regarding your lipids.
Can you go more into that ratio one more time? I just want to make sure I get that.
Yeah, sure thing. So ApoB would obviously be a measure of LDL, VLDL, IDLs, all of the lipid factors. So it gives you much more information than just LDL particles in and of itself. It's kind of all those non-HDLs, and then ApoA would be a measure of HDL and really HDL functionality. So that's what we're using, and and I think obviously everything that we're doing, we're so many case studies where we're really making big differences.
Got it. ApoAs, the HDLs, the ApoBs, everything else essentially.
Yes.
Okay. Great. So looking at, you being a cardiologist, at some point, maybe you get people with hypercholesterolemia coming in. When do you prescribe a statin? Is there a time where are you able to avoid prescribing them most of the time? How does that look?
To be candid about my practice, I mean, the only people that are on statins in my practice are the people that insist on it. So, and those are typically going to be the people that have had a cardiovascular event already. They've had a heart attack, they've had bypass surgery, they've had stents, or somebody with familial hyperlipidemia. And so many people, of course, come in and say, "Oh, I've got a family history." Well, 50% of the population in the United States has cardiovascular disease. Do we all have bad family histories? So we can't blame it on the family, but there is a small subset of people that do have total cholesterols above 300, that have LDL particles that are sky high, that no matter what you do, their ApoBs are high, their LDL particles are high, their LDLs are high, everything's high on them. And those people require significant intervention. I try everything, nutrition, I try supplements. We can go through a whole litany of supplements that I think are beneficial. Sometimes at the end of the day, we reach for a low-dose statin. But once again, it's not very frequent, even in my practice.
Got it. And then with the statins, is there one that you're finding has less side effects? Are you doing like a Zocor, a Zetia, Lipitor? What works the best, and what's like the typical low dose you like?
Yeah, typically I would reach for something like a rosuvastatin, which is the brand name is Crestor. I think we can get away with pretty low dose on that. I think we can dose it 2 to 3 times a week and getting success. But even amongst those genetic hyperlipidemia patients, the statins don't have much effect against them either. So the new kid on the block is the PCSK9 inhibitors, the Repatha injectable. Things that help to increase the LDL receptors on the liver to clear LDL particles out of circulation. I have not prescribed that yet. I have a few patients that are on that from another cardiologist, but I have not written that script yet. This is where I think, number one, the spices actually help increase LDL receptors on the liver. And then my favorite supplement when it comes to lipids and blood sugar and so many other things is berberine, B-E-R-B-E-R-I-N-E. The literature on that is extensive and prolific in so many different things. That's a really exciting product, and that's one of the ways it works. Increases that AMPK enzyme, therefore prevents degradation of the LDL receptors in the liver. Works similar to the PCSK9s, not as dramatic of an effect, but without the side effects, with other benefits, and it's natural.
Got it. So I think that's in one of your cardiovascular supports, right? You put the berberines in there as well?
Yeah, right now we're using a straight product called Berbe, B-E-R-B-E, and anti-cancer, lowers blood sugar, excellent for lipids, improves BPH symptoms, the polycystic ovarian syndrome, PCOS. It's like there's a role for that in everything. So it's a pretty exciting product.
It also helps with SIBO too, small intestinal bacterial overgrowth.
And that's really where all the literature, kind of started off, is as far as what it did for as an antibacterial and to improve bowel health. In fact, I found a study recently that came out about how berberine improves leaky gut, how it's how intestinal permeability is decreased when you put people on berberine. So it's really a kind of the Swiss Army knife of supplements.
Totally agree. Now, I want to pivot one sec. I heard you mention leaky gut, and I know you mentioned a test that you run earlier, test for leaky gut. How are they assessing leaky gut? Is it based off of zonulin or occludin? What are the markers?
Yeah, so in particular, the Vibrant America does a test called Wheat Zoomer, and the Wheat Zoomer looks for leaky gut. It looks at zonulin, looks at anti-zonulin, or antibodies against zonulin, antibodies against actin, and antibodies against lipopolysaccharides, those active components of bacteria that, some of them get into the body, but it shouldn't be a lot. So they're not looking at occludin. I think Cyrex Labs looks at occludin, and it's kind of like Mercedes-Benz or BMW. I mean, they're both high-end products. I happen to like the panel from Vibrant and the quality of the company that I know Vibrant is. But once again, nothing against Cyrex. I think they're both both good options. But Dr. Justin, this is really kind of what I would consider kind of the holy grail of how things happen, right? I mean, now we really can put it all together, where you have the intestinal damage known as leaky gut, bad things get in, immune system, inflammation, oxidative stress. And the immune system comes in with a machine gun, and that machine gun damage kills off bad bacteria and other particles, but it also damages the rest of the body. So the conventional cardiologist just doesn't get it. The conventional cardiologist thinks that coronary disease is a lack of statin drugs. Coronary disease is a cholesterol issue, and they're just totally missing the boat.
And we know so much of the cholesterol can be responding to inflammation. Like cholesterol is kind of this natural Band-Aid. So if we have a lot of inflammation in the gut, that could easily affect cholesterol levels systemically, couldn't it?
Oh, most certainly. Cholesterol is part of that spackle on the wall. There's damage on the wall, and you fill it with spackle. Cholesterol is part of that spackle. Spackle didn't cause the damage; it's coming in to heal the process.
Love that. Now, typically in my clinic, a couple of the tests we'll do all the panels that you just mentioned on the cholesterol. One of the things I have to start working on is the APOe, the APO1 and 2. I got to start looking at that more. But we'll also look at some inflammatory markers. We'll look at highly sensitive CRP. We'll look at homocysteine. We'll look at fibrinogen. What do you think about those markers for inflammation? And are there any other markers that you'd also like to look at too?
Well, I think you mentioned, certainly HSCRP. The most data is on HSCRP, and there's phospholipase A2, which is PLA2.
Yep.
Real quick, if there's anybody out there that's thinking about getting a CT, coronary CT or coronary calcification scan, I'm totally against it. I don't know what your opinion is, Dr. Justin, but I'm anti-radiation. Radiation causes heart disease. Radiation causes cancer. Let's just assume most people have coronary calcification because they do. So therefore, let's just use these lab tests. Let's use maybe CIMT. Let's use endopat markers of vascular reactivity to define health. And then the other inflammatory marker is the oxidized LDL. I mean, that's the pinnacle of the test right there. You're measuring damaged LDL particles that are eventually targeted for uptake by the immune system, and those oxidized LDLs go right into the vessel wall. They're taken up by the immune system. The monocytes would become macrophages, and then foam cells. The foam cells rupture, and then people die. So that's where that goes.
And what's that test? The oxidized? Just call oxidized LDL test?
That's it. Ox LDL.
That's it. Wonderful. Very good. I don't really have a opinion on the calcification test. I'm glad that you brought that up. I know Dr. Davis, I think he's a cardiologist as well. I think he has spoken highly of it in the past, but you're not liking it more just from the radiation exposure side of it?
Right. Yeah. Bill Davis, up in Minnesota, he became famous cardiologist because of a test he did called Track Your Plaque, and that was his opinion. Keep doing CT scans. Well, the more you keep doing CT scans, the more you're going to create coronary artery disease.
Totally.
Radiation causes cancer. Radiation causes heart disease. We know from young guys who had Hodgkin's lymphoma. They got radiation to their chest. They all have severe coronary disease. They all have valvular damage from it. So it's just a test. We don't need it. And that's, frankly, I think that's a big reason why insurance doesn't cover it either, because it's just not a useful, beneficial test. If you're a 50-year-old male, let's just assume you've got coronary disease. Now let's do something about it. So, once again, I'm totally anti-CT scanning. Radiation, I think, was a factor that killed my father, working as a cardiologist for all those years. Right. So, let's avoid it.
Totally. So I'm going to kind of go through a couple of rapid fire questions. HSCRP, do you like that below 1, below 0.5? What's your range for that?
I think the lower the better on HSCRP, no doubt about it. I mean, HSCRP, not only is it a marker, but it is a stimulator for dysfunction in the body. When they infused lab rats with high sensitivity CRP, they all came down with hypertension, endothelial dysfunction, and eventually coronary artery disease. So it's not just a marker; it's actually a negative when it's floating around. So we got to get that lowered.
Absolutely. And how about homocysteine? Do you like that? Below 8?
Certainly, homocysteine. I think 8 is a nice position.
Okay.
Somewhere between 6 and 8, I think
Yep.
is good. We certainly don't want it too low because homocysteine has a purpose. We got to
Mhm.
lower that number down, and of course, everyone knows about the B vitamins, but another
Yes.
secret trick to lower that down through another part of the methylation pathway is betaine.
Ah.
And betaine you get in your digestive enzyme if you
Yep.
take a good betaine HCl product. That tremendously works as well. Sometimes the B vitamins just don't get it done, and of course people have genetic SNPs and whatnot. But the betaine really helps to lower that down. But even more importantly, of course, it's for digestion, and everybody has not enough stomach acid as opposed to too much.
And the betaine's the trimethylglycine, right? Same
Yeah,
thing.
trimethylglycine is a fantastic methylator, but it is different from the betaine
Okay.
molecule in and of itself. But the betaine does contain 3 methyl groups on there, so there is some similarity. But it works really well.
Loving the brain candy. Awesome. And I know the whole story behind, and maybe our listeners don't, but the whole Kilmer-McCulley story of homocysteine. Basically, he was laughed out of Harvard trying to talk about the connection with homocysteine and heart disease. Basically figured out that certain B vitamins, in particularly B6, P5P or folate or B12, ideally methylated B12s, help lower that homocysteine. Do you find that taking those types of nutrients, those methylated B vitamins that I just mentioned, does that actually lower homocysteine? And does that actually correlate, or I should say, is that a direct causation because of that lower homocysteine to less heart disease?
Well, I think that the literature unfortunately has not been kind to the B vitamins to lower to make a difference in cardiac endpoints, heart
Yes.
attack, stroke, dying, etc. So it clearly lowers the number down on homocysteine, and I think that's certainly a positive. And I can only postulate that number one, they're using inferior supplements. Number two, it's not part of the whole program. You have to put it in context of eating the right foods, living the right lifestyle. If you take a McDonald's eater and try and lower the homocysteine, with vitamins, you're probably not going to make a big difference. I think it's all part of the big picture in our holistic practices.
And they're probably working from the antiquated theory of like, let's fortify some milk, some orange juice, and maybe some toast with some synthetic crappy B vitamins. Obviously, that's not going to fix the underlying issue.
I would agree.
Okay. So you think, looking at if we just give the healthy B vitamins that we just talked about at a higher level, but we make the diet changes, you're seeing in your clinical practice a reduced risk and a reduced outcome of heart disease?
I mean, I think so. I don't have a big, study to point to that we're doing it, but I certainly think that, once again, that as you're improving the lipids, you're improving the homocysteine, you're improving the omega-3s, you're improving the thyroid and blood sugar and all the things that we're doing. I think it's making a huge difference.
That's great. And you mentioned the only people you're really prescribing statins for, I want to just make sure I heard you right, people that are already on a pre-existing statin that are coming to see you to manage that. Or you said number 2 is people that were hypercholesterolemia. Is that correct?
Yes, yeah, that's correct. I mean, I'm not using it too often. Frankly, I'll use the berberine, I'll use the bergamot, I'll use red yeast rice, I'll use
Yes.
Binders in the gut. So
Yes.
organic India psyllium husk.
Yep.
And just really trying to increase that fiber in the diet. And and those are my therapies. But I think once you address the basics, I mean, just getting sunshine converts excess cholesterol back into vitamin D. I mean, how simple is that? And that's free. You don't have to pay guys like you and I a lot of money to do that. I mean, it's just right there. So
I know, that's great, because I have a couple of patients in my practice that have the hypercholesterolemia. And are you typically diagnosing that off of like the PCSK9, the LDL receptor, and the FH markers? Is that what you're looking for, that diagnosis?
Well, I think there's a lot of different, genetics, and I think you labeled the big ones there as far as why people have hyperlipidemia. But once again, if they have a total cholesterol that's in that 350-400 range, they have LDL particles above 3,500. I think that's a pretty good sign that they've got familial hyperlipidemia. But sometimes you see people that are just dysmetabolic syndrome. They're overweight, hypertensive, and they have an LDL particle number of 2,800. Those are not the familial people. I mean, those are people that just have all the bad, all the bad habits that lead to the lipids.
Yeah, and these patients are actually expecting this interview, so I told them I'd ask some of these questions for them. But we talked about some of the natural things we could do. Would you be comfortable would you want someone to be on a statin, even if they're trying not to be on a statin with those conditions, if they're doing the berberines, if they're doing the CoQ10, if they're doing some of the red rice yeast and all the things you mentioned, or would you still want them to be on a low-dose statin as well as everything else?
No, for the most part, I don't want them on statins. I think about myself personally, and I wouldn't want to take a statin under any circumstance. So I don't push them on that at all. It's really kind of patient driven. If they say that they want to be on it because of what they've read or whatever, then they can stay on it. I'm not going to totally dissuade them from it. And listen, Dr. Justin, all we can do is give people the facts and say, hey, listen, when you take a statin drug, your risk of having a cardiovascular event is reduced from 7%, for example, down to 5.5%. And if you want that 1.5% benefit, go ahead. But I think in my plan and your plan, we're going to get down to close to 0%. And when we explain that to people, they get it. It's not just about moving numbers. It's not about moving numbers at all. It's about lowering risk of heart attack, stroke, and dying. And in any statin study, under any circumstances, the benefit is small.
And what does the research say? Because you talked about the 1.5% benefit. What does the research say, though, on increasing chance of Alzheimer's, diabetes, and cancer being on a statin?
Well, listen, I mean, obviously, it increases diabetes risk. There's no doubt about that. Cancer risk is kind of equivocal. Listen, there's a lot of studies that come out touting the benefits of statins, and I think you have to look at a lot of those with a inquisitive eye and saying who's paying for the studies, who's doing the studies, what's the motivation behind it. But all these diseases, whether it's heart disease, cancer, dementia, this is not from a deficiency of statin drugs. There's a reason for it, and the natural doctor finds that reason.
And I've also heard too that the NT, or the number needed to treat for a statin, I think is 99. So that means 99 people have to take that drug for one person to be helped by it. Are you familiar with that?
Well, most certainly so. And I love number needed to treat, and that's what anybody should ask their doctor regarding heart disease or stroke prevention, or certainly cancer prevention, chemotherapy. Hey, if I get this chemotherapy, what's my number needed to treat? How many people need to take chemo for one person to benefit, and what is that benefit? Is it a 3-month benefit? Is it a 5-year benefit? Yes. Give me numbers. Give me numbers. That's what we encourage, for that. But listen, statins come in different categories. For primary prevention, for example, in women, the statin data, number needed to treat, as far as, heart attack reduction, it's around 100, 150. For women, primary prevention, statins do not decrease mortality at all. For men, it gets a little bit better. Studies are mixed. Secondary prevention is where statins, quote unquote, shine. And in that scenario, you can make number needed to treat regarding heart attacks, about 1, in 30 to 40, mortality data, maybe, 1 to 70 to 80. But then again, listen, the pharmaceutical companies are doing the studies. There's a better way. In any of these scenarios, 39 out of 40 people don't get benefit after taking the drug every single day for 5 years.
That's
I
crazy.
think we can come up with a better plan. By the way, real quick, we had talked real quick about betaine to lower homocysteine. I just want to correct myself, real quickly. I think about it, TMG, you are very astute and correct. It's another way to do it. I just happen to like using betaine HCl because it's a kind of a 2-in-1 thing.
Totally.
We lower the homocysteine while we're really cranking up digestion.
Yeah, I totally agree. And most patients, I find, as you know, when they're stressed, they have lower levels of stomach acid. And if we up the stomach acid, it's a 2-for-1. You get better digestion and you get the reduction in some of that homocysteine. So I agree.
Love it.
And when you said secondary just a second ago, you meant secondary benefits, like the person's already had a heart attack. Now they're coming in to get treated with a statin. That has a little bit more benefit than preventative.
Correct. Yeah, somebody really is going to shine in the people that have had a heart attack. There will be some better data on people that have had bypass surgery or angioplasty, but it's really in those post-heart attack people where there is the evidence of success. But once again, it's not about lowering the risk from 7 to 5.5. It's about lowering the risk from 7 to 0. Exactly. And the medical doctors cannot offer that, and Dr. Justin, you and I can, which is totally cool.
Exactly. And then in your practice, are you putting those secondary people on statins, or are you still doing all the natural stuff that you already reiterated earlier?
Yeah, no, I mean, listen, if you want to go on statins, go see somebody else. I mean, you don't have to pay me as a private, physician. Go see your, pill-pushing doctor, and they'll be happy to give it to you along with a 3-minute office visit.
Yeah, right. And I know
Yep.
with the statins too that they block that HMG-CoA reductase pathway. And if we look at the metabolites from that, you have the mevalonic acid that comes after it, which is the precursor to CoQ10. So does that mean when you're managing patients that are already on statins, like you mentioned, are you making sure you give extra CoQ10 as well?
Yeah, certainly, and I'm sure as you do, I measure CoQ10 levels, and we see where people are at. And typically, it doesn't take much to get to where we need to be. But you're right. I mean, the downstream ramifications of the HMG-CoA reductase inhibitors and blocking that enzyme are just catastrophic. What it does to DNA and RNA replication. As you mentioned, CoQ10, the squalene, which has roles in the body, and then dolichol. Dolichol is another cholesterol derivative, and dolichol, interestingly enough, is found in the substantia nigra in the midbrain. In the midbrain and the neuromelanin cells. And wouldn't you know that that Parkinson's, my father died of a Parkinson's-like illness called progressive supranuclear palsy, and my father is a cardiologist. He took Lipitor. So this is very, very important to me. And yeah, when you see that dolichol is in that area, now you're not going to make dolichol because of the drug. We have the total linear connection on how it works, and it's scary and it's sad, and we need to stop it.
Dropping some truth bombs here. I love it. Very, very cool. Now, also one more question too here before we wrap up. Looking at CoQ10, which we just talked about, do you like the reduced or the oxidized form, the ubiquinone or the ubiquinol? And what does the research say?
Excuse me. I personally use ubiquinol. I think there's good data, of course, on the use of ubiquinol. But frankly, all the original data regarding CoQ10 was on ubiquinone. So I think that both serve a purpose. I think if you test levels, you can do that. But I think pretty much most people are going towards the ubiquinol version. But once again, I think either one that you're taking, I think is fine. And go from there. And
the ubiquinol, that's the reduced version, right? That has the extra electron to it?
Correct. Okay. Correct. And, so it's more the activated form, but the body shifts, pretty easily, to and from both of those. And, I think when you're healthy, you're going to convert, one to the other very easily.
Love it. Well, is there any other really important info that you wanted to talk about, but you haven't yet had a chance to bring it to the surface?
Well, I think, once again, our paleo ancestors ate, our ancestors ate paleo food. That's number one. Number two, our paleo ancestors went to sleep with the sun down, awoke with the sunrise. Let's not forget about that. Our paleo ancestors were not in the artificial light. Our paleo ancestors were in the sun all day long, and they were naked. So these things are free. Appropriate sleep is free. Appropriate sunshine is free. The food is easily affordable. Get rid of the Starbucks and all the other garbage. So I think that's about it, man.
I think that's great. And last question here for you. If you were on a desert island and you only could bring one supplement with you, one herb, one supplement, one nutrient, what would it be?
I would say it's got to be probiotics.
Okay, probiotics. I love it. Very good. And I just wanted to give you props, Dr. Wolfson. You are a clinician as well as a researcher. You're in the trenches. There are a lot of people that are out there that are postulating and coming up with their theories on what's best based on the research. But you're in the trenches doing it yourself. So I really appreciate that.
You got it, Dr. Justin. It was an absolute pleasure to talk to you. I'll be happy to do it again anytime.
Absolutely. And again, that's the Doctors Wolfson with a DR. We'll put the link below in case you guys miss it so you can click to get access. And also check out Dr. Wolfson's book, The Paleo Cardiologist. And he also has, we didn't even get a chance to do it. We'll have to put you on for a part 2 over at vaccinesreveal.com for Dr. Wolfson's awesome info on vaccinations.
Sounds fantastic. I appreciate it. And here's to health.
Thanks a lot, Doc. Appreciate it. Take care. Bye.
Got a question for Dr. J? Go to BeyondWellnessRadio.com and click the questions button. Then tune in to hear the answer. Also, if you like the show, click below to review us on iTunes. For more Beyond Wellness Radio, go to BeyondWellnessRadio.com.